Good morning. My name is Prof D'Alto. I'm from the University Hospital of Naples, the Monaldi Hospital. I run the PH clinic in my hospital. It's one of the most important PH group in Italy. So I'd like to thank the PHAE Europe patient organization for their kind invitation. And my task today will be the initial combination therapy for PAH. These are my disclosure in last 5 years. And this is the agenda. I will explain why using initial combination therapy for PAH, which kind of combination and for which patient, because the therapy should be targeted on patient, and what are the strengths and weaknesses of initial combination therapy, because this is a very nice tool that we can use with a lot of experience, because should also create some problems. So just the first slide to introduce the problem of PAH, you know that there's an important pulmonary vessel remodeling. So as you can see, there's an important narrowing and pruning and reduction of the vascular bed, in particular in the severe forms of PAH. What we try to do with therapy is to partially or completely reverse this condition that is a very severe condition in case of PAH. So coming back, we can observe that over the time, the expert recommended sequential combination therapy, and the recommendation has been stronger over the time. In Venice 2003, they advised in the combination therapy that may be considered in this patient. 2008 should be considered. In this 2013 is recommended. So the recommendation became stronger over the time. But what about the upfront therapy? You know that sequential therapy is starting with one drug and adding a second or a third drug. Upfront therapy starting from the beginning with 2 or 3 drugs together. So the concept became at the beginning of 2013-14, and just the 2018 World Congress on Pulmonary Hypertension face this problem very, very nicely. In particular, let's give a look to the proceedings that came out after the last World Congress, the 6th World Congress in Nice, that told that patients that are naive, once the PH diagnosis is confirmed, must be stratified. If the patient is at low or intermediate risk, you should start with initial combination therapy. If the patient is at high risk, you must start with initial combination, including not only oral, but also parental prostanoid. So oral combination or combination including parental prostanoid. There's just a residual role for initial therapy with one drug for patients at low or intermediate risk. What does it mean? That just a few number of patients, small number of patients that are with a mild disease, for example, patients that are vasoreactive must start with one drug, this calcium channel blocker, increasing the dose, or patients that are old, are some comorbidities, patients with very mild disease that are part of screening program, or patient that has been treated long term, remain at low risk despite using just one drug, or particular form of PAH, group 1 pulmonary hypertension, such as veno-occlusive disease or HIV infection and so on. So there's a role, but so far I think that the tendency is to use double oral upfront therapy or triple upfront therapy, including parenteral prostanoid. This is very important. This proportion is not more than 10 to 15% of the patient that must be treated with monotherapy from the beginning. Let's give a look to what does it mean, risk assessment. Actually, that not only one tool to define the risk parameters of the patient, but we need a polyparametric approach. As you can see, we have different European score. We have also the REVEAL risk score, that is American risk score. I don't want to treat in deep this risk stratification model. Anyway, The French score is very easy, and it considers just 4 parameters. The simplified form, 3 parameters: functional class, 6-minute walk, 2 invasive parameters, right atrial pressure, cardiac index, that are included also in the Swedish and in the German score. This is compare a European score. The French simplified consider NT pro BNP instead of right atrial pressure and cardiac index. So it's quite easy. Anyway, whatever is the risk stratification model, we should consider that, I'm sorry, this slide is quite busy, but let's give a look to the percentage of patients that are at low risk at baseline at first follow-up in the 3 European papers. In the Swedish paper, that were 22.6 low-risk patients at baseline, that became 29. So not a great effect of therapy if we consider that pushing the patient in low-risk category is the goal of our therapy. A little bit better in the compare study from 12 to 24, so it's doubled, but it's quite low, the proportion of patients that are at low risk at first follow-up. But let's give a look to the French cohort from 17 to 41.5. So the French approach is much better, but this depends on the use of initial combination therapy. So if you want to achieve an increase of the population that is at low risk, you must use initial combination therapy. In the French cohort, about half of the patients used initial combination therapy, and the results of increasing the proportion of patients at low risk is incredibly better than other groups. And the first randomized clinical trial, probably the most important of the double oral upfront therapy, is the Ambition study that has been published in 2015 and compared the safety profile and the efficacy of initial combination upfront with ambrisentan and tadalafil versus ambrisentan on tadalafil on monotherapy in treatment-naive patients. And this approach achieved 50% of relative risk reduction and 13% of absolute risk reduction. So less events if you start with double upfront therapy instead of one drug, and it was allowed to increase the regimen dose in patients started with monotherapy, adding the second drug. But in this case, starting with 2 drugs from the beginning is much better. But it is the lesson that we learned from the cancer, from the left heart failure, and so on. We usually start with 3 drugs from the beginning, and just increase the dose, up titrate the drugs during the follow-up. And what's happening in real life registries, we in our Italian network group, that is the IFNET group, collected many data on this. Let's give a look. This is the first paper that we published in 2018 regarding this population. Naive patient, 69 patients in upfront therapy with double oral or parental prostanoid versus 69 monotherapy. As you can see, the patient that used upfront prostanoids or upfront oral, that are the yellow and the red patient, have a larger reduction of the PVR, and this larger reduction in the 2 cartoons in left resulted in reduction of the volume. This is the right ventricular and diastolic area, and an increase of right ventricular ejection fraction. In other terms, if you start with upfront therapy, including or not prostanoid, you achieve a reduction of the PVR that is much more important, and a better remodeling of the ventricle. This is a very important result. And just a couple of years later, we collected the long-term follow-up at 2 years of all patients that started with the ambrisentan and tadalafil, similar to the Ambition protocol. These are 106 patients that have been treated, naive patients with different forms of PAH, mainly idiopathic PAH, that started with upfront combination therapy, ambrisentan and tadalafil. And as you know, as you can see, at 2 years follow-up, better 6-minute walk test, better NT-proBNP, better functional class, better risk score, I will show you in next slide, and better hemodynamics, in particular a reduction of 37% of the PVR. This is a very important achievement. But giving a look to the risk score, let me remind you that the goal of our therapy is reaching the low-risk category for the patient that is represented in green here. Whatever is the risk stratification model that we use, in this case, this is represented by Reveal risk score, that is the American score or the French score. The proportion of green patient that at low risk is much higher during the follow-up. But if you want to see the cup half empty, we can also consider that, okay, the green patients are more than the baseline, but a vast proportion, about half of the patient, more than half of the patient at 2 years follow-up remain in intermediate or high-risk category. This means that probably double upfront is a good approach, but is not enough, in particular for some patients. And this is another paper that we published in 2020. In both cartoons, left and right, the columns represent the risk status at baseline, and the colors, the risk status at the end of the follow-up, that is a 6-month follow-up. As you can see, the third column of both cartoons is yellow or red. This means that the patients that are at high risk at baseline remain at high risk or became intermediate risk patient during the follow-up. This is very important because patients that are at high risk, if are treated with double oral upfront therapy, never became patient at low risk. That's the reason why something in this patient we need something more. So what about using parenteral prostanoids in triple upfront therapy? This is a good option, but we know that, as you can see in left, for example, using sub-Q treprostinil, we should have no problem at all at infusion site. We should have some mild problems in terms of pain, but we should also have some problems that are sometimes very important in infusion site, not only pain, and also using of epoprostenol that has been used intravenously should have some problem. Also, the delivery system is quite big. The infusion site need a catheter that is a Groshon Minikman catheter, a catheter that is implanted in a surgical theater or into the cath lab. Anyway, this just to say you that parenteral prostanoid is a fantastic option, but is just for a very expert center. What about using triple upfront therapy? The first paper, very convincing, despite it's just a few number of patients, is this paper from Olivier Sidon that has been published in 2014. As you can see, 19 patients that were very severely healed in functional class 3 or 4 with incredibly scaring hemodynamics, 1.6 or cardiac index, were treated with bosentan plus sildenafil plus ED epoprostenol from the beginning. And in this patient, at first visit at 4 months, at the final follow-up, that is about 2.5 or 3 years later, as you can see, all patients were in functional class 2 or 1. The 6-minute walk increased from 2020 for 514, and the cardiac index normalized from 1.6 to 3.6. This is a very important achievement. Also, the PVR were about normalized. And this was a sort of screen from Olivier Sidon, the French group, that was very impressive for us, because starting from 2014, we started using for severely healed patients also triple upfront approach, including parenteral prostanoid. And this is what we did and what we published just 2 years ago. Is a retrospective study, small as well, just including 21 patients. In the Olivier cohort, there were 19. As you can see, these are the classical patient without comorbidities. Young patient, 44 years old, all patients were in functional class 2 or 3, with an incredibly high NT-proBNP. The mean value was 3,000. Some patients were not able to perform at all 6-minute walk distance test, and the mean value was 150. All patients had a high Reville risk score, and hemodynamics was terrible because cardiac index was 1.8 and right atrial pressure 13. So we used a similar approach, not sildenafil, bosentan, and epoprostenol, but ambrisentan plus tadalafil plus subQ treprostinil from the beginning. And what we achieved is, first of all, that all patients were alive at 2 years follow-up. This is a very, very nice achievement because, you know, the expectancy of life for this patient, if left untreated, is actually is not more than the median value is 6 to 12 months. All patients were alive. As you can see, the patients were all in functional class 2 or 1, but 2 in functional class 3. The 6-minute walk increased from 150 to 430. There were an important reduction in proBNP from 3,300 to 500, and all but one patient dropped in the low risk category according to the American Reville risk score stratification score. And let's give a look to the hemodynamics that were very nice as well, because right atrial pressure dropped to 1/3 from 13 to 5, PVR dropped to 1/3 from 16 to 5.5, and the cardiac index doubled and normalized actually from 1.8 to 3.5. And the mean pulmonary pressure dropped by 1/3 from 60 to 42. That is good achievement because, you know, if you increase the flow, that is the cardiac index, of course you partially increase the mean pulmonary pressure, but the hemodynamic data, these hemodynamic data are incredibly nice. And otherwise, if you compare this patient with the historical cohort that started with one drug, as you can see, we obtain an important reduction of the PVR from -40 to -80% in this patient. And this is reflected from the very nice reverse remodeling of the right ventricle, because we obtain an important reduction of the volume. Actually, this is right ventricular and diastolic area with echo bidimensional. And we also obtain an important increase of the function because we have an important increase of the right ventricular fractional area change. So if you push very low the PVR, you obtain a reverse remodeling in terms of reducing the volume, increasing the function of the right ventricle. That is very nice for the survival of the patient. And these data have been confirmed largely in this large retrospective analysis from the French group, from Athénaï Ducry, the group of Olivier Sibon, Marc Ambert. This is retrospective analysis. 1,600 patients. This is a quite complex slide. Anyway, in the left part of the slide, there are 3 columns representing the monotherapy, the dual combination therapy, and the triple combination therapy. This is the initial approach. And the colors represent the severity of the disease. The hot colors, the red and the orange, represent the patient at high risk. The cold color is the green, the light blue is the patient at low risk. And the other the 3 columns on the right represent the follow-up. As you can see, let's give a look to the 3rd column in the left and in the right. The patient that have been treated with triple combination therapy were the worst patient at the beginning, because the vast majority were in red or in orange, so high-risk patient. But at the follow-up, they were the best. Because this is the largest proportion of patients that in green or in blue. In other terms, the patient that started with triple combination therapy were the worst at the beginning, were the best at first follow-up. And this is also demonstrated in these Kaplan-Meier curves, because the survival was much better if the patient started with triple upfront therapy, and the transplant-free survival curve as well. So this is a very nice result. But I want to just report you briefly a clinical case. This is a patient with systemic sclerosis and pulmonary arterial hypertension that came, that was not part of a screening program. So it was in 2016 that came in our hospital. It was 56 years old at that time with open infected finger ulcers, right heart failure with severe fluid retention, no important lung comorbidities with a terrible value NT-proBNP. And this is the scaring images of the echo scan. As you can see, pericardial effusion, very large right heart, high pressure, inferior vena cava very dilated, and right heart catheterization showed the numbers that are scaring as well, very high right atrial pressure. Consider that the normal value is 2-3 millimeters of mercury, and below 8 is acceptable. This is 21 of right atrial pressure. The cardiac index was very low, is 1.5. And we started with very strong therapy with inotrope, diuretics, oxygen, and we use the triple upfront. That is the approach that we are very familiar with ambrisentan plus tadalafil plus subcutaneous treprostinil from the beginning. So this is an upfront approach, and we titrated the 3 drugs very quickly over the time. And this is what we achieved. This is this fantastic lady with me with the treprostinil delivery system. At baseline 1.5, at 3 months and 12 months, the cardiac index was 2.7 and 3.1. Let's give a look to the resistance, 13, 5, 3.5. That is very important results in terms of hemodynamics. But what is impressive is for imaging people is the reverse remodeling of the right heart, as you can see. From November 2016 to November, in 1 year to November 2017, there were a quite complete normalization of the shape of the heart. So disappearance of pericardial effusion, reduction of the volumes of the right heart, the atrium and the ventricle, and this is a very important result that we achieved. Just a few words, what about using a triple upfront therapy with oral prostanoid? Actually, this is not 3 pills, it's 3 drugs, because, you know, for example, PD5 or Rio have 2 or 3 pills, Selexipag at least 2. Anyway, this triple upfront with the 3 oral drugs, the results from the Triton trial is quite discouraging, because the trial was Selexipag plus macitentan plus tadalafil versus placebo plus macitentan plus tadalafil. In this case, the primary endpoint where the PVR was failed. Other exploratory endpoints were achieved, but as you know, when the primary endpoint is failed, the study is considered negative. What is encouraging in this patient, for example, there were a risk reduction of the events using triple oral upfront. Anyway, at time we don't have enough evidence for starting with the triple oral combination therapy. And I find very, very smart the suggestion from the German group, the Cologne Consensus Conference. They say that if you have an incident patient, stratify the patient. If this is a classical PAH patient, I mean, no comorbidity, quite young patient, you can push very hard and very early. So for patient with low intermediate risk, start with the double oral combination, forget monotherapy. If it's an high risk, start directly with combination therapy, including parental prostanoid, so triple therapy. If it's a patient that is a little bit older with comorbidities, with some left heart condition, pulmonary condition, be very careful, start with 1 drug and recheck the patient and escalate quickly the therapy, but starting with the triple upfront in this patient or double upfront should be a little bit risky in terms of side effects. And just a couple of slides, I'm quite finishing my presentation. I think that nurse have an important, very important role in our network for the patient, because they take care of the patient and monitor the patient. They can give the support to the patient and caregivers. They can listen to the patient need, empower the patient, encourage the patient. So I think that in a group that is an important group that is interested in the care of patients with pulmonary arterial hypertension, the nurse should be involved very, very actively in the daily practice. And what is very, very important in my opinion, that you must have an honest discussion, an open discussion, and this involves physicians, nurses, caregivers, and patients, of course, to manage successfully in a very strong therapy that should be, as should be the upfront therapy, in particular if it includes parental prostanoid. For example, you should discuss how to manage drug tolerability. This is a very important point. If the patient has some side effects, what can you do? You must communicate the treatment plan to the patient. What are your expectations? Because, you know, the point of view of the patient should be a little bit different. You are interested in survival. You, as a doctor, are interested in a good hemodynamic response, in reverse remodeling of the heart, but the patient is interested in daily life. He or she asks you if can go shopping, accompany the children at school, do this, their daily life and so on. So it's very, very important, because you have to compare your expectancy and the patient expectation as well. And finally, you should educate the patient to provide emotional support. This is very important, because the patient must have the feeling that the group, the working group, is taking care holistically of the patient and the caregivers. And this is very, very important, because the patient sometimes has either problems that should be gynecological problems or work problems, social problems, and so on. You should take care of the patient at 30-60 degrees. So the take-home message from me is that initial combination therapy is for sure beneficial in incident of newly diagnosed PH patient. There's the strongest evidence for ambisent and tadalafil due to the ambition trial, that is the most robust study. The real-world data, many data have been produced from our working group in Italy, support the rationale for using many drugs targeting multiple pathways in PAH, and probably a more aggressive approach can achieve a lower risk profile. We don't have to forget to use a timely parental prostanoid. In particular, triple upfront is a good option for severely ill patients. And finally, nurses play a key role in a comprehensive approach to PH. This is very, very important, and they are an important part of our organization. Thank you so much for your attention.
So thank you so much for being able to help us again. A lot of people have watched your presentations, and there has been sent a lot of questions for you. So I thought maybe we could try to go through the questions, and if you could see if you can answer them, please. And of course, this is your presentation that people have seen about initial in combination therapy. So I think we should just dive right into the first question. And this is me. Why is it not necessarily recommended to give upfront initial therapy to old people when they are 75 years old or older? Isn't PH potentially even more risky for them due to the comorbidity reasons? Is it side effects of drugs one is worried about?
Oh, thank you so much, Al. This is a very important question, and this is one of the most important points of my presentation. In our opinion, actually, people that are older have more comorbidities, and for this reason, using 2 or 3 drugs expose this patient to a high risk of side effects. Otherwise, you know, people that is in the 70 or in the 80 usually have a certain diastolic dysfunction, so they can have a fluid retention, leg edema, and so on. So our behavior is to start with the single therapy, to check very, very quickly this patient, and if it's the case, to increase with a very quick add-on approach.
Okay. The French registry plus studies show very clear positive result for upfront combination therapy. Why do not all do like the French and the studies suggest? Is it for economic reasons?
Yes, maybe. I think that nowadays the right way, and all people are that are interested in femoral pulmonary hypertension are oriented to using double or triple upfront therapy. So I think that the French approach is an accepted approach. I think that over the time will be the prevalent. Of course, there are some economical issues, but we can overcome this issue.
Yeah, no, I've seen the same in Norway. I think all patients at least get the double therapy, initial double therapy. Third question: is it a requirement to include parental therapy when using upfront triple combination therapy in order to achieve optimal results? Would it still be advisable to use 3 oral pills for class 1-2 patients?
This is a good question. Actually, you know, the Triton study that addressed the question of using 3 pills, 3 oral drugs as a upfront approach actually failed the primary endpoint, despite achieving some of the secondary endpoint. But, you know, if a study failed the primary endpoint is considered negative. I think that at least in our approach, we use the 3rd oral drug quite quickly in patients that are in 2nd functional class, that are patient or in patient at intermediate to low risk. But I think that the triple approach upfront with the parental prostanoid is still the better in patients that are severely ill. I mean patients that are high risk, or patients that are high to intermediate, because, you know, intermediate risk is a very, very vast area. There's a gray area that is in the border between intermediate and high. And this is very important to not delay the use of parental prostanoid on this patient.
Yeah. What treatment recommendation would you give to patients that reside in countries with limited access to therapy?
This is a very important point, because actually we are quite lucky, because in Italy you can use all drugs that are available for pulmonary arterial hypertension. I think that there are some economical issues in other countries that are not Western countries, for example in Eastern Europe or as well as in Asia, in Africa and so on. I think that we can do at our best, of course, and start with the double upfront oral therapy. If they do not have parenteral prostanoid, maybe a triple oral upfront should be nice. But of course, it depends on the availability of the drugs in the single country.
Yeah, yeah. No, I know, for instance, in Ukraine, the situation I know a little bit about since my wife is from there. They have sildenafil and they have bosentan. So I guess that they should try to start with both of those drugs for newly diagnosed patients.
Yes, correct. I'll do this.
Yeah. But is there anything else one can do? I'm thinking more of an holistic approach. Maybe they should also be given advice about lifestyle and things like this? Do you think that would have any effect, or?
I think that is a good association. You know, the only trial that addressed the problem of using double upfront instead of monotherapy is the Ambition trial that included ambrisentan plus tadalafil. But there are different experience from other groups showing that whatever is the endothelin receptor antagonist and the PD5 inhibitors that you use, you can achieve good results. If you have just bosentan and sildenafil, you can use. There's a study showing this is quite, you know, the results were not so exciting using this drug, but in the common daily clinical practice, we achieved very nice results. Of course, we can also, this is off-label use, in absence of availability of parental prostanoid, you can also increase the dose of PD5 inhibitors. You know, the first study that was done in US for sildenafil considered 20, 40, and 60 3 times a day, but it was licensed just 20 3 times a day because of the same results on the 6-minute walk, despite better results on the hemodynamics.
Yeah, so you think it's safe for them to go up to 40 or 60 3 times a day?
If you don't have, of course, you should start with 23 times a day, but if you don't have other weapons, if you don't have parental prostanoid, this is the only thing that you can do.
Yeah. You very nicely described the benefits of a holistic approach. What role do you think a patient association can play in this respect?
I think that patient association play a key role because they advocate for patient, they create a link, and they also, you know, are a sort of area where the patient can share each other what happened regarding their bodies, their disease, and so on. I think that the best way is to involve the patient association in our plan, in our decision. What we do is encouraging patient to contact patient association, because patient association understand what are the centers, they know what are the centers that can take care of the patient, where are they, in which countries, which cities, which area. Sometimes they help, for example, in daily practice problem. For example, during the COVID pandemic, the Italian Patient Association, AMIP, take care of some patients that were impossible to have drugs from the pharmacies. This is a very important point.
Yeah. And I noticed this myself when I was newly diagnosed. It was, of course, very important for me to get the information from the doctors and the healthcare system. But on the other hand, to talk to another patient, and especially a patient that had lived for a long time with a disease, also gave a totally different perspective on the disease from my side, and it was easier to live with when I knew that you could have also a future for and look forward to many years if you were lucky. So I think also to be able to speak to other people with the same disease is very good for you.
Correct. And we also organize with our Italian association some meetings that are informative meetings for patients, just to clearly show what is the disease, because sometimes the patient, you know, is a patient that is an incident patient, a newly diagnosed, so is completely afraid, is scared of what's happening, what is this disease, how can I do, and so on. This is very, very important.
Yeah. Bulgaria, what kind of methods do you use to diagnose Pvod? And what do you recommend? And do you recommend lung transplantation to patients in an advanced stage?
Yes, this is a good question as well. I think that the best way to diagnose Pvod is a high-resolution CT scan of the lungs, because there are some particular signs that are septal thickening, ground glass, mediastinal lymph node dilation, and so on. Sometimes there are some effusion in pericardium or in the lungs. This patient have ever precapillary pulmonary hypertension. So the CT scan and the right heart cath are the key points, but right heart cath can be the same in terms of numbers of the PAH. Once you have diagnosed Pvod, this is a Achilles heel of patient, of physician that are in the field of pulmonary hypertension. Beginning, sometimes it's so difficult to diagnose PAH instead of Pvod, in particular in some patients that can have some overlaps. For example, the scleroderma patient, the connective tissue disease patient, they can have a certain vascular disease and a certain Pvod. So regarding the therapy, the proceedings recommend starting very, very carefully with one drug. You can and you should give diuretics to this patient because there's the risk of a certain edema in the lungs. You should avoid the use of parenteral prostacyclin in this patient because you can induce pulmonary edema. That should be a big problem for this patient. Regarding the lung transplantation and the approach to the therapy, we start with one drug. If the patient goes better, we add the second one, and we usually stop to oral therapy. If the patient is a quite young patient, as is in the age for having lung transplantation, next step instead of prostanoid is lung transplantation. Finally, we consider also genetic counseling for this patient and look for some genetic mutation, because sometimes about in 50% of the patient there's a AF2K4 that is a gene that is there's an alteration in this gene provoking Pvod.
Another question from Bulgaria. Do you consider that triple therapy for patients with PAH in the third functional class is necessary and gives better results?
Yes, this is probably a gray area, but in our center, we prefer for patients that are in third functional class. Usually the patients that are in third functional class are ever at high to intermediate risk. In the big area of intermediate risk, they are quite close to the high risk. So this is not completely yellow, not completely red in terms of color, it's orange color. So in this patient, we prefer adding parenteral prostanoid because delay in the use of prostanoid should be very, very dangerous for the patient. Sometimes some centers use too late parenteral prostanoid, and when there's an advanced disease, despite the use of parenteral prostanoid, there's no recovery, no reverse remodeling of the right heart. So it's better to anticipate the use of parenteral prostanoid, and we do in this case.
Mm-hmm. If you start with a parental drug early, and then you see that the patient is improving, could you at a later stage consider taking them off this drug and go back to oral therapy?
That's a good question. We do this very, very rarely. We just have some cases, for example, very young patient that completely normalized with no comorbidities and so on, usually female, that completely normalized hemodynamics. If you achieve this with a not so high dose of parenteral prostanoid, you can down titrate and try to stop or to switch to oral. But this is an exception because, of course, the vast majority of patients that use parenteral prostanoid remain in parenteral prostanoid if they don't have side effects. This is an exception, but could happen. Could happen. I spoke with the French group, with Olivier Sigbon, Marc Ambert, the group, French group, and they agree that one of the options should be start very, very early and very, very strongly with the parenteral prostanoid into a triple combination upfront approach, and try, if you completely normalize, to down titrate the parenteral prostanoid. The other scenario is the patient that is in double therapy, that is not is in intermediate to high risk, and you add parenteral prostanoid to this patient. This patient is not a good patient to down titrate and stop the therapy. It's a completely different scenario.
Yeah, because I guess from the patient point of view, it's also the life quality issue. So I guess, you know, if the patient has big problems living with the pump, that
I agree, Al, because I think that it's very important to explain to the patient that your goal is not giving parenteral prostanoid, is that patient get better. So when you start parenteral prostanoid, we reassure the patient, because we say that the central point and the most important point of our plan is that patient is getting better. This means that if the side effects overcome the benefits of the prostanoid, I don't care that PVR is reduced. But if the patient has particular side effects, we of course have to stop parenteral prostanoid. So is this one-way therapy? I think that you should never stop. Of course, if you have side effects, you must stop, because no one can consider this condition.
Yeah. Question from Slovakia. Is it easy to persuade insurance companies to reimburse triple upfront therapy in Italy?
Actually, we don't have insurance companies, because the health system is public, so no patient pays. We are quite lucky on this. No patient pays for his drugs, despite they're very expensive. But I think that the best things to do, because I have to persuade our pharmacy hospital, because our pharmacists say us, Michaela, you are spending lots of our money for these patients. I tell them that if you spend lots of money, but it's the right patient, you save lots of money. From an ethical point of view, you are doing the best for your patient, and this should be sufficient, should be enough for giving this drug. But also from an economical point of view, if you give this drug that are very expensive, you reduce the rate of hospitalization. So you induce the health system to save money. I think that this is a good response. And this is the same that we use, for example, for direct anticoagulants that are more expensive than warfarin, and so on. So there's an ethical aspect that by itself should be sufficient, but there's also an economical aspect, an organization aspect that is in favor of using these drugs. The problem is to refer to an expert center, because the problem is that you don't have to waste money, because you waste money not if you choose the right patient. If you choose the right patient, despite it's expensive, you are doing a good job. If you are wasting money, if you give these drugs to a patient, it's not the right patient. I mean, for example, the patient with left heart disease, the patient with lung disease, this is the wrong patient. And also a PD-5 inhibitor that is not so expensive is wasting money in this patient.
I remember yesterday we had a chat with Professor Rahegi from the United States, and we talked a little bit about insurance issues there. And he said that what they need to do is that they need to show the studies that show the beneficial effect of triple upfront therapy in order to persuade the companies to pay for it, because then they saw that there had been research on this area.
Okay.
You mentioned anticoagulant. I just had a question about blood thinning, because this is something that I've heard the doctors talk quite a lot about. Do you think maybe blood thinning is because of historic reasons, something that is given to PH patient, and if you don't have any CTEPH and don't have irregular heartbeats, that maybe it's not necessary to give blood thinning medication?
I can understand. Sorry, I had a problem with connection. Hold on.
Oh, okay. Blood thinning medication.
Okay.
I heard some doctors say that one give blood thinning medication to PH patients maybe because of historic reason, because this was what they gave in the beginning when there was nothing else to give to them. And that maybe if you don't have CTEPH problem and if you don't have irregular heartbeats, maybe you don't need to take blood thinning medication as a PH patient.
Yes, I don't know. It's a controversial problem. I don't have a univoc answer for this question, huh?
No, but in Italy, do all PH patients go also on blood thinning medication, or?
Yes, they use this, and if a patient has a CTEPH, for example, this patient that underwent the pulmonary endoarterectomy. After the pulmonary endoarterectomy, our surgeons prefers giving warfarin, because they are not so confident with use of direct anticoagulation for this patient. It's different for the patient that survived to acute pulmonary embolisms. In this patient, you are allowed to giving direct oral anticoagulation, but in this case, of course, you have to follow the patient. If the patient needs PE in the pulmonary endoarterectomy, you have to shift later to warfarin.
Yeah, but if you're on idiopathic PAH patient,
we at the beginning, some years ago, we used to anticoagulate all patients. We don't use now for incident patient to anticoagulate, but some patients that have a very poor right ventricular function and are historically in oral anticoagulation, we left oral anticoagulation as well in these patients.
Okay, but some of them don't need to go on anticoagulate medication.
Yes, but I guess that the new guidelines that will be published in August will not recommend oral anticoagulation routinely in PAH patients. So I think that the results are quite controversial. Not for sure, patient with scleroderma and patient with congenital disease must not use oral anticoagulation. For idiopathic patients, there are conflicting evidence, but the recommendation is becoming weaker over the time. So you should choose a tailored therapy for the patient.
Yeah. A question from Finland. What is CCB therapy?
It's calcium channel blocker. It's the oldest therapy for PAH. Actually, it works just in a limited numbers, a limited proportion of patients. The calcium channel blocker are very cheap drugs, nifedipine, amlodipine, and so on, that are usually used for patients with systemic hypertension. We have high pressure as a hypertensive patient use these drugs. Why can you use in some patients, which are the patients with the PAH that can use these drugs? Are just the patients that are vasoreactive positive. You know, the vasoreactivity test is performed during right heart catheterization in patients with idiopathic, irritable and drug-induced pulmonary hypertension, actually in idiopathic mainly. Just 10%, 10 to 15% of patients respond to nitric oxide, that is the drug that is used. Calcium channel blocker is used chronically, not for the vasoreactivity test. For the vasoreactivity into the cath lab, we use nitric oxide, the inhaled nitric oxide. If the patient has some characteristics, for example, the mean pulmonary pressure is below 40, drop more than 10 millimeters of mercury, and the cardiac output remain the same or increase, this is a vasoreactive patient. You should use the calcium channel blocker and recheck very, very carefully the patient, because the calcium channel blockers are considered an efficacious drug just if the hemodynamics is quite normalized. So this half of the patients that have a vasoreactivity test positive and that are put on calcium channel blocker are long-term responders. So given 100 patients with idiopathic PAH, 10 to 15 response to vasoreactivity tests. If you put this 10 to 15 on calcium channel blocker, about half of these patients, to 5 to 7, 8 patients, will be long-term responders. The other, you should use calcium channel blocker plus the common drugs.
And I guess these patients are quite lucky, because once they start to take calcium channel blockers, their pressure is almost reduced to normal in many cases.
Yes, yes, and you know, what is of note is that, for example, systemic pressure does not change, despite this patient use a very large dose of calcium channel blocker, for example, 15 milligrams of amlodipine or 120 of nifedipine and so on. And these are quite lucky patients, because in the field of in the group of PAH patients, they have a very good prognosis that and their survival is quite similar to the normal population. It's just taking calcium channel blocker. This is probably a sort of vasoelastic or reactivity problem of the pulmonary arteries. There are not plexiform lesion and so on. So it's a very benign disease.
Yeah. Has it been speculated why some patients react to it and others not? Is it because maybe they have been able to catch this disease at a very early stage before too much damage has been done to the lung?
I don't have an answer for sure for this question. It's very complex. I think that I've seen that some patients that are vasoreactive are long-term responder. We catheterize again the patient, but the hemodynamics is completely normalized. The patient is functional class 1. After 6, 7, 8 years later, despite they are continuing taking calcium channel blocker, the pulmonary pressure increased, the cardiac output reduced. So this patient that we have considered over the time long-term responders are not further mortal responder, and we have to add another drug. So I don't know what's happening in this patient. I don't think that is a matter of starting immediately the therapy. There's something wrong probably in the endothelium of the pulmonary circulation, but it's just an hypothesis. I don't know.
Yeah. What is vasoreactivity test? I guess you explained that.
I already explained this.
Yeah. Question from Spain. Is there any evidence patients initially treated with one therapy would have had a better prognosis if they had been treated with triple therapy from the beginning?
Actually, no, because there's not a head-to-head comparison. In this group, I start with 1. In this group, I start with 3. But our feeling is that you know, the strategy, hit hard, hit early, should probably be better, because we have seen, for example, in our paper that we published, also in the French publication from the University Bonn group, that a severely ill population of PAH patients that have a life expectancy very, very low, very short, if treated with triple therapy, so they are themselves controlled. Of course, this is a limitation of the study, have a very nice prognosis. Let me do an example. We studied 21 patients that were in functional class 3 or 4. All patients were at high risk. These patients started with triple oral upfront therapy with parental prostanoid, included parental prostanoid, and all patients survived at 2 years follow-up. So, of course, this is a very small population, but the survival of all patients at 24 months, 2 years follow-up, is an incredible result, because the life expectancy of this population is very, very low. Many patients were in functional class 4 with leg edema, ascites, right heart failure, 4,000 or BNP, 1.5 of cardiac index. So this patient is very severe. I guess that if you start, this is the same for example, for left heart failure or for malignancy. If you have left heart failure or if you have a cancer, you don't start with one drug and after you wait for add another one, after to titrate and so on. You start with the 3 or 4 drugs from the beginning. The problem are, of course, the side effects, and you titrate the drugs over the time. I think that this is probably the best approach also in the PAH. If the question are there strong evidence, I think that there are evidence, but there are not honestly head-to-head comparison for this.
I saw a chart. I don't know if it was your presentation or someone else's, but they showed the effect of mono, double, and triple therapy, and you saw much better survival for triple therapy over time. But I was surprised to see that there was not so much difference between mono and double therapy.
Yes, it's for my presentation reporting some cartoons that were taken from the Athénée Bouclier and Olivier Sitbon study. Actually, so two observation of these 2 comments. The first comment is that this is a retrospective study. So I think that there are not strong evidence because there are no prospective randomized clinical trial addressing the 2 different approaches. But the French study is very important because the patients that started with the triple upfront therapy were the worst at the beginning in terms of risk stratification, but at the end of the follow-up, at the first follow-up, were the best. So this is very important. Regarding the survival, you are absolutely right, because the survival curve, the Kaplan-Meier showed an advantage in patients treated with triple therapy and with the same course of mono and double therapy. But in the same papers, I did show, if you consider just patient in intermediate risk stratification score, there was an advantage of double therapy instead of mono. So in other terms, for a patient with severe pulmonary hypertension, I mean the patient at high risk, actually, it's better to start with a triple therapy, including parental prostanoid. For patient with in intermediate risk, it's better to start with the double upfront therapy. Of course, if you have a patient at high risk, starting with the double or with mono, mono S is the same, because it is a mistake anyway. You know, that's the reason why it should is like no difference between double and mono. But in intermediate risk, double is much better.
Okay. Another question from Spain. Do you recommend your patients to contact patient association? Yes, you already answered this.
Absolutely, yes.
Yeah. And this is very good, because I see in Norway we have data protection issues. So we don't know who is new patients. So we are depending on the doctors to recommend them to contact us, because they will not give us list of new patients.
But you know, sometimes the patient contact on the web and try to understand what is the disease. So they discover that there is some patient association. But we push the patient to have contact with patient association, because they feel not more alone. They consider that there's a sort of network that included the physician, the referral hospital, the general physician, the patient association, and so on. I think that we have also for a severely ill patient the nurse home program. There are some nurses that, and we pay, so for the patient is completely free, that take care of the patient at home. I think that is very, very important to consider that you are not alone. You are in a network that is taking care of you.
Yeah. Based on your professional experience with PH patients, what would be the ideal combination of a patient with idiopathic pulmonary hypertension?
I think that I don't know it, because once again there's not a head-to-head comparison, but I think that the strongest and the most robust evidence for using a double upfront therapy is in favor of starting with ambrisentan and tadalafil due to the ambition study. Regarding the third drug, we used treprostinil, sub-Q treprostinil, we are very confident with. The French group use more epoprostenol, but I think that is very important to choose the parental prostanoid that you are confident. You must have an honest discussion with the patient, explaining the pros and cons of the sub-Q or the intravenous. And after you must be ready to change your direction. For example, if a patient has a problem with sub-Q due to the side pain and so on, and you are not able to manage this condition, you have to propose the patient to use intravenous and to shift. But it's very important not to delay the use of parenteral prostanoid.
Yeah. In Norway, they also have started with implanted pumps. Have you started this in Italy, or?
Not yet, but we are ready to do this. Now they have the CE market, the authorization, and we are going to start.
Long question. In most cases, we start with sildenafil and anthelion. If you have, already told us that to treat pulmonary hypertension, it is advisable to be aggressive from the beginning of the diagnosis. How would you see tadalafil macitentan from the beginning under your recommendation at the same time that intakes are reduced? What would be more effective than sildenafil bosentan initiation?
In my opinion, Hal, despite the most robust evidence is in favor of using ambrisentan plus tadalafil, I think that ever PD5 plus endothelin receptor antagonist association do work. So I think that you can use whatever you want, actually. I sometimes ask the patient, if the patient thinks that is a problem, taking a pill 3 times a day, I actually start shifting to other approach. For example, tadalafil, you can take the 2 pills together, 40 milligrams in just 1 shot. So it is an option. Actually, tadalafil macitentan or tadalafil ambrisentan in terms of numbers of pills is better, but is an option.
Yeah. Hungary, we have kept hearing that parental prostanoid proved to be the most effective in combination therapy. What can be the reason why the oral version cannot be so effective?
Yes, because actually the parenteral prostanoid have a much stronger effect on the pulmonary circulation. So in terms of a reduction of the resistances, they are much better. And we also noted, and we published this data, that if you achieve an important reduction of the PVR, that are the resistances, that is, reflects and represents the pulmonary circulation stiffness. So if you reduce the stiffness, if you reduce the PVR, that are the resistances, the right ventricle do a better job and the patient goes better. So the strongest in reducing the PVR, that are the resistances, are probably the better in terms of prognosis. That's the reason why these drugs are much stronger than other one, and we can use in advanced phases from the beginning.
Yeah, and maybe also because you get the drug directly into the area, which is
Yes,
like,
probably. But you know, for example, yes, that's the reason why, for example, if you use the same drugs with different route of administration, for example, we participate in the treprostinil oral protocol, their efficacy is a little bit less than parenteral, of course. This is.
And maybe this is also why there is a lot of interest and excitement around new drugs that are coming that you breathe directly in and into your lungs.
Yes, this is another good point, because, for example, in patients that have a pulmonary fibrosis, you know, the patient with pulmonary fibrosis and pulmonary hypertension are patients that are part of the group 3. So no good giving, it is not allowed giving drugs for PAH in this patient, but there's a recent study with inhaled drugs in this patient published on the New England Journal, showing that also in patients with fibrosis, with lung fibrosis, some inhaled drugs should be useful. That's the reason why we also tried over the time with the inhaled Hyloprost, or now with the inhaled treprostinil that's not available in Italy, to address these patients. Probably is good, but that's a very small area of patients.
Yeah, yeah. Besides the medication, it is important to improve the quality of life of the patients. Are there any tricks and tips that can make the life of those using the medication pump easier, like waterproof tape to cover the site, pain relief for the site? What is the most convenient place for the line?
You know, I start from the end. I don't know what is the most convenient place for the line. Some patients prefer, for example, the arms. Some patients prefer the stomach, the abdomen, a little bit higher, a little bit lower. You know, it depends on the innervation. So, for example, some patients tell to me, doctor, when I put the needle in terms of sub-Q treprostinil, for example, if I put in the right side, you have a lot of pain. If you put in left, no pain at all. I prefer on the arms, for example, during summertime. You know, it depends. Sometimes the patient discover his body and establish what is the best area for himself or herself. Regarding the tips and tricks, I think that when we start using parenteral prostanoid in the patient, we do a long counseling, because you have to explain to the patient what are the pros and cons of using this therapy. It's not like giving a pill. Come on, take this 2 times a day, 1 time a day, and it's okay. Because you have to say this patient honestly, this is a very important approach, because your disease is quite advanced, but there are some possible side effects. You know, there are sometimes it's double-edged swords. So what is important is to communicate and to tell the patient that you have a plan. I mean, you should have, for example, some stomachache. In this case, you take the drugs, for example, if are oral, so let's say Lexipag, after meals. If you have site pain, in case, for example, of sub-Q treprostinil, please use this drug, use paracetamol, use codeine, use these strips and so on. Don't change every week, because the maximum of your pain is the second or third, 4th day after there's a decrease of the pain. You are free of pain usually for 3, 4, 5 weeks. So change every month, every 6 weeks and so on. If you have some diarrhea, take cloperamide. If you have some increase of the temperature, take paracetamol. If you have some problems, this is the phone number. We have a free phone number, 24/7 days. This is very important, and the patient must understand and be confident that you can manage every possible problem. In this case, the patient feel in the middle of a system of care and accept also the possible side effects. If you do this and the patient understand that the beneficial effects overcome the side effects, he is happy to tolerate, for example, also the side pain. But if you do, okay, that's not my problem, you have pain, ask your doctor, your general physician, the patient immediately discourage and stop therapy. So once again, giving the parenteral prostanoid is a sort of complex strategy, and this complex strategy should be the referral center with the doctor, with the nurses and so on, that must take care in a holistic way of the patient, should be a network, the patient should be assured. If despite this, the patient has some problems, you must be also prepared to down titrate and stop the therapy. And there are also some tips and tricks using some waterproof device to put on the delivery system and so on. We have some packages for this.
Slovenia, have you ever tried to add treatments such as medical hypnosis?
Honestly, I don't. I'm not sure that this can work.
No. Bosnia-Herzegovina, when can we expect therapies which you mentioned to be recommended as good practice examples? I don't know if you understand the question or.
When can we expect therapies you mentioned to be recommended as good practice example? I can understand what is the meaning of this question.
No, neither do I. Belarus, for what types of PH is initial combination therapy recommended except IPAH and CTEPH?
Actually, the only indication for PAH therapy is group 1, is PAH. That is idiopathic scleroderma patient. For example, in congenital patient, as well as in patient remaining in group 1. For scleroderma patient, okay. Idiopathic patient, familial, drug-induced, okay. For patient, for example, with congenital heart disease, we use for portopulmonary hypertension, as well as for Pvod. We usually start with one drug, recheck the patient, and add the second one, because a patient that is has a congenital heart disease natural history is a complex patient that have a sort of equilibrium in the shunts, because the shunt is usually bidirectional, sometimes more right to left than left to right. So you have to be very, very careful with giving drugs, and you must titrate the drugs. We usually start with one drug. Regarding CTEPH, once we have achieved the diagnosis of chronic thromboembolic pulmonary hypertension, we refer the patient to the surgeon that is expert to endoarterectomy. If the surgeon, and this happens not more than 10 to 20% of the patient say that the patient is not suitable for surgery for comorbidities or because the lesions are too distal, we consider BPA or drugs. In this case, we start with one drug again in CTEPH, that is riociguat, that is the only license, and after we add an endothelin receptor antagonist using usually bosentan, that is a little bit evidence in this case, and if not sufficient, we add as a third line parenteral prostanoid.
Another question from Belarus. Are the studies on the using initial triple therapy in patients with congenital malfunctions, with Eisenmenger syndrome in particular?
No, they're not. There is a study from the Nikas Korosayer and Irene Lang group, starting with treprostinil, subQ treprostinil. We also published a paper with the add-on approach with the treprostinil sub-Q in patients with Eisenmenger syndrome, but there are no studies convincing for using a triple upfront in Eisenmenger patient. Of course, this doesn't mean that you must not use a triple upfront approach. It depends on the patient. If you have a very severely ill patient, you can, and you are obliged to use something that is very strong. You can do this, but in the single patient with a very tailored approach. But the recommendation is not to starting with triple upfront therapy in this patient.
I've heard that the Eisenmenger patients might be a little difficult to assess because of their oxygen level is always so low. So it's a little difficult to understand when they are doing worse than before and so on. Do you have any comments on this?
Yes. Consider how that actually the patients that have Eisenmenger syndrome have a goal for peripheral oxygen saturation is not 100% as in other people, 95 to 100, but is about 85. So 85%, 86 is the maximum that they can achieve due to the central shunt, because usually there's a bidirectional shunt or prevalent right to left. So in this case, what we do, because in this patient that not indication for giving oxygen routinely, we do an oxygen test. We just put the patient with oxygen 2 liters per minute. And if you achieve an increase of the peripheral saturation that is significant, I mean, for example, from 75 to 85, we refer the patient to the pulmonologist, because these are the patients that probably must use oxygen plus, of course, a PHAE therapy. But we can start from the convincement that the maximum goal for this patient is 85, 86 of the peripheral saturation.
Yeah, and also I guess you might have the case that you get to a point when you give oxygen that it doesn't help to give more because they were not able to utilize all the oxygen.
Absolutely correct.
Yeah. Belarus, are there studies data on the use of combination therapy in children?
Yes, there are a few data. Of course, there are not robust studies such as ambition study, for example, in adults. But there are some evidence for this patient. Once again, we have had some. The therapy should be tailored on the patient. We usually start with the monotherapy and do a rapid increase of the therapy, adding a second drug very, very quickly. But sometimes we have used a double upfront oral therapy or also therapy with parental prostanoid. I think that it depends on the patient and the therapy should be tailored. So there are recommendations that are more based on the daily practice and expert opinion. But if the question is, are there any studies or data that robust for in this category of patient, the answer is not, but it doesn't mean that you cannot use.
Is monotherapy effective only for the first, I guess, first functional class?
Yes, actually, the proceedings of the last World Symposium held in Nice in 2018 identify some categories that can have a beneficial effect using monotherapy. In this group, for example, are considered patients that have many of course, patients that are the ideal for calcium channel blocker, that are the vasoreactive patients, but these are another category, or patients with a very mild disease that usually are patients that are part of a screening program. What does it mean? For example, if you screen the familial or patient the relatives of patient with familial idiopathic PAH, and you identify at the very beginning of the disease with the Pvod is 3.5, the mean pulmonary pressure is 26 and so on. These are patients with very mild disease. You can also start with one drug and recheck the patient. Or, for example, scleroderma patient. So if you identify this patient, but these usually are not patients identified by chance, but are patients that are part of a subject that are part of a screening program. Other patients are, I said this before, that are patients with some associated form of PAH, for example, congenital patient or patient with portopulmonary hypertension, HIV, and so on. Or patients that are quite old, due to the probability. It was the first question, what about patients that are older, more than 75? These are the categories where you have to start with monotherapy. In some categories, because this is probably enough with a very mild form of disease. In the other one, with the idea to up-titrate after you are sure that there are not side effects.
Reveal has a scoring to assess patient risk. However, ESC guidelines groups patients into 3 cohorts. How are patients recognized or categorized into such groups in practice? Which colors they have the most?
Yes, that's the great. This is a great question, and it's a big problem because whatever is the risk stratification model that you use, we exactly know what to do in high-risk patient. We also know what to do in patients that are at low risk. But the big deal is that the intermediate risk category is quite large and is quite heterogeneous. I mean, into the intermediate risk category, there are some patients that are very close to the red area, that is the high risk category. So we usually are very aggressive in this patient. Otherwise, in patients that are at intermediate to low risk, we usually have more sort of watchful waiting behavior, and sometimes do something that is minor in terms of increasing therapy. I mean, for example, we give a third oral drug that should be selexibag, or we do a switch from PD-5 inhibitors to riociguat. But in this kind of patient, to avoid the progression, we don't give parenteral prostanoid, but we consider to up-titrate to parenteral if the patient does not drop in low risk. Of course, the guideline suggested to be not happy if the patient is yellow, is an intermediate risk category. What the piece of puzzle that we are looking for is how to better categorize the patients that are in intermediate risk, because there are missing information of right ventricular performance, and probably using modality imaging such as echo or MR, you can complete the puzzle. I think this is a new step that we are trying to do.
I just was thinking while you were talking about maybe in the future there will be more use of precision type, personalized type medication, and phenotyping has not come to a point yet where you can decide which drugs would be perfect for a person. But how do you decide what drugs to use, and maybe if one is not effective, maybe a different type of drug would work better? How do you decide what drugs to use and change drugs?
In terms of in the same category, we don't have some preference. We usually, for double upfront oral, try to start with ambrisentan and tadalafil due to more robust evidence. But we sometimes also start with, for example, with macitentan and tadalafil. We have had great results as well. Regarding the parenteral, when we consider the patient for parenteral prostanoids, we try to use epoprostenol in more advanced forms. We try to use subQ treprostinil, for example, in patients that have congenital disease due to the risk of paradoxical embolism, infection, and so on. And we decide case by case what to use. But there are no, recommendation regarding let's start with this compound instead of this other one, because once again, there are not head-to-head comparison.
But could it, in theory, be that the person reacts not so good to one drug, but would react much better to a different drug because of his body type?
Yes, this happen. We don't know why. But sometimes more due to the side effects. For example, I've seen some patients that, for example, have some fluid retention with ambrisentan. They don't have at all with OLS with macitentan. I don't know why. Probably there's a different effects of the circulation. And this is the same, for example, between PD-5 inhibitors and Riociguat. There are some patients that, according to the replace study, we switched from PD-5 inhibitors to Riociguat, and they went absolutely better. There are some other patients that feel absolutely the same, and a few patients that experience side effects. So, of course, you know, a posteriori, after, you can explain everything, but at the beginning, you cannot forecast what will happen.
Yeah. Last question. Data suggests that initial upfront combination therapy is beneficial. What is the reason that despite these results, only a very small number of patients are receiving combination therapy in real life? Is it due to reimbursement policy? I guess we answered this before.
Yes, I think that there are two answers for this question. One is the reimbursement policies, but once again, it's not an issue in Italy. I think that another problem is that many centers are not so confident. You know, are not so confident with using parenteral prostanoid. So they are sometimes not so expert because expert centers are very, very shy. They start with one drug, after reject the patient. If it's the case, they add another oral drug, and sometimes refer the patient to the referral center very, very late. When the patient is very advanced, you put the prostanoid, but the results that you are achieving is not so good. So the reason is that parenteral prostanoid is a strategy, is not a therapy, is a simple therapy. It's a strategy that includes also a team that taking care of the patient, some nurses, a network in case of your ability and your skills in manage the side effects. I think that at least in Italy, this problem is much more important than the reimbursement policies.
Yeah, yeah. Okay, that was the last question, and I'm sorry we spent over an hour of your precious time, and I know you are a very busy person. You're working hard at helping fellow patients. So I would like to thank you so much for the time you spent both presentation and also answering all these questions. As you can see, there were a lot of questions, so people are very interested in what you presented. So thank you so much for your time.
Thank you so much all, and hello to all patients and your patient association, and I thank you for your continuous effort in this field. Thank you so much. I think that our work is as facilitated is much better thanks to you. Bye-bye. Have a nice day.
Thank you. Yeah. Bye-bye.